Good evening, and welcome to Doctors on Call. I'm Dr. Paula Termuhlen, Regional Campus Dean at the University of Minnesota Medical School, Duluth campus, and I'm your host for our program tonight on elder care. Our panelists this evening include Dr. Mark Boyce, a geriatric and elder care specialist with Essentia Health, Dr. Jeff Copeman, a family physician with the Fairview Mesaba Clinic in Hibbing, and Dr. Amy Greminger, a geriatric and elder care specialist with Essentia Health and faculty member at the University of Minnesota Medical School, Duluth campus. Our medical student volunteers answering phones tonight are Kaylee Evers of Rochester, Mitchell Moe of Montevideo, and Courtney Wertinen of Hibbing. The success of this program depends on you, the viewer. So please call in your questions and we'll do our best to answer them. The telephone numbers can be found at the bottom of your screen. And now, on to tonight's program. So, Dr. Greminger, one of the things that we've heard a little bit about in the news recently has been older people driving and when is it time to give up the driver's license? I think this is something many families are challenged by. Certainly the royal family's been challenged by that recently. So talk to us a little bit about how you advise your patients and their families.
You know, I think whenever we talk about driving, the first thing I like to think about is, are they able to meet the physical demands of driving? Things like being able to see properly, which can become an issue as people age. Are they able to move their feet properly to get to the pedals, which also can become issues as people age? And if they are having problems with that, is there something that we can do to help troubleshoot it? So I think a good first stop would be, one, considering family members' concerns, and then two, talking to your primary care doctor.
Very good. Dr. Copeman, how about yourself?
I agree. And one of the things that we run into quite a bit is driving and dementia. And just because somebody has a diagnosis does not mean that they cannot drive. The patient that has mild to moderate dementia, studies have shown are actually a safer driver than the average teenager. There's less fatalities and less mortality. Really? Yes, from the elderly with mild to moderate dementia than teenage drivers. But the type of driving too also, I advise, it has to be limited. I mean, we don't suggest somebody with mild to moderate dementia be going out on busy highways. Things like going to the grocery store, going to church, not going out during high traffic areas are perfectly fine. So I always try to stress that just because somebody has a diagnosis does not mean that we take away their driver's license.
Interesting. So, yeah, Dr. Boyce, talk to us a little bit about how you advise patients.
Well, I also wonder about where these ideas are also going to go in the future with technology. Maybe we'll rely on, at least in cities, more on Uber or Lyft or other, maybe even driverless cars. But it is important that if I'm having some troubles with my vision, my hearing, or my mobility, that I at least get the help that I can. I can restrict my driving to certain times, going to church and those sorts of things, and avoiding bad weather. But I also have to plan that if it doesn't work well, then my next step needs to be to someplace where I can catch the bus or where there's more convenient transportation.
You know, I've recently heard this term, retirement from driving. Have any of you heard about that? What we might think about that?
You know, I do think that it's a matter of, I see a lot of patients that eventually at some point in time end up not driving toward the end of their life. I don't think it's something that happens for everybody, but it's certainly very common in the United States. And so I think a lot of times a theme that I have with geriatrics in general is just planning for the thing that's most likely. And so if we think that it's likely that it's going to happen at some point in time, it's better to pre-plan for it so that you can manage it in a way that's helpful for you, helpful for your family, and preserves decision making regarding that for as long as you can.
Yeah, maintaining independence. So, Dr. Boyce, we have Arthur from Duluth has a question. I think this actually dovetails very nicely with our conversation. And he would like to know, what are the advantages and disadvantages for aging in place in your home? So what is aging in place?
I think that first off is that we all come to a comfortable place where we're living. Most of us get that chance. And so if that comfort is very good, our benefits of living there are high, then that would be a place where we want to age in place. But if we develop a spreadsheet, and that's really what Arthur is asking us to do, if this, then this, and kind of all the choices, then we start to look for that, what are the benefits? So myself living in my home, I can work on my baskets. So I can keep those hobbies going. I can keep my expenses perhaps a little less. Although if I was paying somebody to shovel snow this week, I think I would take that because the drifts got pretty high. So there's some advantages and disadvantages that probably change over time for my ability too. So aging in place to me means aging, and it might be in an apartment eventually for me, a place where I can be comfortable, still keep some hobbies, have transportation, and yet not have a lot of the difficulties of yard work, snow removal, the cost of keeping a car and things like that. So that's what it means to me. There's kind of that decreases in the, I don't need the four-wheeler, I don't need the boat, I'm not using them, so I don't need the space to store them.
Yeah, so Dr. Copeman, I mean, can you just run through some of the other options that people may have if they feel like they don't want to stay independently in their own home anymore or an apartment?
Yeah, there's a whole continuum of care that's available, and all of it mostly depends on functional the function of the patient. There's something called assisted living, which has become very popular now. What assisted livings are is basically patients will move into a place where there's an apartment, but there's supervision. You still are free to come and go if you wish. You have your own space. You don't have a skilled need. The next level of care, of course, we look at is nursing home or rest home. Now, people that go to a nursing home usually have more needs to maintain independence. They need help with their bathing, their dressing. They may have a need for physical or occupational therapy. There's also some of the apartment buildings where there's no, like Dr. Boyce said, where patients just move into an apartment complex. They may have some staff there, but they're really not doing any of the medical care. So it's kind of a continuum based on what the functional needs are.
Yeah. And Dr. Greminger, I know you've had some experience caring for patients in that skilled nursing setting.
Yeah, I think I always tell patients that the best environment for them is the one that they can get the support that they need, but is the least restrictive. And so certainly, I think it's wonderful that we have so many options now for everything from aging in place at a senior focused apartment to the assisted living to the more supportive services that a skilled nursing facility can provide.
So we have a few other questions, and we really want to thank our callers. We have a caller from Moose Lake who would like to know if any of you recommend Prevagen to your patients for memory loss.
No.
No. Okay.
I think that the evidence is that exercise is the best treatment for really memory loss, but also for prevention of memory loss. I don't think that there's any medication that really helps, and I don't believe that extract of jellyfish helps either. So most of the studies are poorly constructed, and there's too much variation and too little control. So I think that it doesn't help. I'm sure that some folks feel it's helped them preserve some memory. The other thing that is very good for prevention and also treatment of memory loss, so both in regards to those trying to prevent but also treating dementia, is group activities. So staying involved with church, being involved with a coffee club, bowling, doing something that's continuing to engage you in a relationship is actually really good for your brain.
So along those lines, what about some of the things now, for example, I enjoy doing like the crossword puzzle type apps on my phone. And so think a little bit about, and then there's been some sort of mind games, if you will, to help preserve memory. Have any of you have any experience or thoughts about that?
I honestly think that I look at that as exercises for the brain. It's no different than younger people going out for a jog. The studies have shown that doing things like that does help preserve memory for a period of time. Interestingly, I just read something that one of the things that really helps with early dementia as well as preserving memory function is music. Music tends to open up a variety of connections in the brain, very similar to if you're doing puzzles. And so a lot of people in memory facilities now are engaging in choir, in listening to music. So not only performing it, but listening to it helps preserve some brain function.
Wow. Wow. Well, we have another question. We have a caller from Superior, Wisconsin, who would like to know, is there anything that the elderly can do to improve their balance? Which I think is such an important question right now, given the condition of our sidewalks and streets.
Yes, I would not suggest trying to improve your balance by walking on our current sidewalks and streets. That would not be where I would go right now.
High risk to benefit.
That's right.
Risk to benefit.
You know, I'm a big fan of recommending just continued physical activity and walking. You know, I think walking is actually very good balance training for a lot of balance preservation for a lot of people. I think that sometimes the less we do, the less we're able to do. Sometimes we become more restrictive of our activities because we're scared. And that's not to say that there's no reason to be, but pushing ourselves to try to do those things to maintain our current level of function, I think is very important for people. We heard Dr. Boyce talking about the importance of exercise for many different reasons. One, it keeps you physically able to continue to do those things. It keeps you more mentally able to to continue to do the things as well. So I'm a big fan of walking.
Yeah.
There is evidence that Tai Chi, which is a form of movement, is helpful. Actually, controlled studies that suggest that it does help in balance. And I would always encourage, particularly if someone can't rise from their chair without the use of their arms, if they have to push, I would always encourage a physical therapy consultation.
Very good. Very good. Well, we have another caller from Cloquet this time who asks, when they take their blood pressure medication, just like the doctor tells them to, they can't seem to get up off the couch. Well, what should they do? And I think this sort of opens a question around medications and some of the effects that medications can have.
I might take that. One of the most common side effects that we see of antihypertensive is something called orthostatic hypotension. What that means is that when patients go from either a lying to a sitting or a sitting to standing position, there's a tendency for the blood pressure to drop. And when the blood pressure drops, you can get dizzy, you can, in worst case scenarios, pass out and fall. And so I always encourage patients that are on antihypertensives to get up slowly, to get from a lying to sitting and a sitting to standing position slowly. It also is important to maintain hydration because that will help support the blood pressure. But that's a very, very common side effect that we see, particularly in the elderly, as our blood vessels tend to become stiffer as we age, and so they don't contract to maintain the blood pressure as good as it can be done in younger patients.
Sounds like the message is be kind to our bodies and take it slowly.
Yes. Yeah.
So I think another thing to consider with that is if that person was really having a hard time getting up consistently, I might also suggest that they talk to their doctor who prescribed the medication about that particular side effect so that they can help to balance that. A lot of medications do have side effects. We see side effects extremely commonly in elderly patients, and doctors are aware of the existence of side effects, but they manifest very differently in different people. So I think it's always really important to have that good communication so your doctor knows how it's affecting you and can advise you accordingly.
Yeah, very good. So we have another caller who wants to know, since we've been talking a lot about different terms, is there a difference between dementia and Alzheimer's? And then I'm just going to throw in their memory loss. We've kind of talked a little bit about all three of these tonight, and so who'd like to field that one?
I'll try that one.
All right.
I think about dementia as calling it blue genes. There's lots of different manufacturers of blue genes. So Alzheimer's is one blue gene, Levi, and Lewy body is another one, Lees. Those are the two biggest. That's why I chose them. So dementia is the overall category, and then Alzheimer's, Lewy body, frontal temporal dementias. Those are the subcategories. Now, when I come to mild cognitive impairment or memory loss, I might be using that as a phrase to try to pinpoint that there is change, but I can't tell what it's due to. Maybe it's due to a low sodium. Maybe it's due to a medication side effect. And so maybe it's not any one of these dementias at all, but it is something else. So if I'm seeing cognitive change, I have to be careful as to what it's due to. I can even see cognitive change with anxiety that gets out of control, or depression that's out of control, or very subtle. So
poor sleep.
Yeah, and I've seen it with patients who have to be admitted to the hospital. So someone who may be doing very well at home in familiar surroundings, and then you need to bring them into the hospital for one reason or another, and their sleep patterns are disrupted, and things change. So, yeah. So when we have, like I said, we use these terms a lot. Can we talk a little bit about some of the testing that we can do to sort out maybe what type it is, because sometimes that can drive a little bit around some of the, whether it be medications and maybe when to even start medication, things like that?
Well, I think that one place to start again is with your primary care doctor. That's a theme that we'll have tonight. There are cognitive tests that you can get from your doctor or from an occupational therapist sometimes. One of them, they have very specific names, like a mini mental status or a MoCA or a, which is short for Montreal Cognitive Assessment. And what those do is those tend to classify patterns of deficit in thinking. So different kinds of illness have different patterns of deficit. Some give you problems with recall. Some give you problems of recalling things a long time ago. Some give you problems with really more decision making. And so it's interesting to look at the patterns that those tests elicit, and then try to match them up with the history. The tests are never a substitute for a good history. What's happening in the patient's life, how things have progressed over time, all of those things are things we really take into consideration when we try to make a diagnosis for somebody.
And one of the things is that we always try to make sure that we're not looking at what we call as a secondary dementia, meaning that there's a treatable underlying cause. And so when patients will go in with some memory change, some cognitive change to do the testing, but we also look for things like hypothyroidism or abnormal thyroid will cause dementia. As Dr. Boyce had mentioned earlier, depression and anxiety can look just like dementia, and we have to tease that out. So oftentimes we will do blood work. In certain cases we'll do imaging, which means like a CT or MRI to make sure there's not a tumor or a stroke or something that may be contributing to that memory loss. So.
Okay. Well, so we have 3 callers, and I think this is such an important topic. I want to just tell you where they're from. So Montevideo, Hoyt Lakes, and Superior, Wisconsin. And the theme is the following. What kind of resources are available for individuals who want to stay in their homes? What other alternatives might we have around caring if someone's unable to stay in their home? And then specifically, the Aging and Disability Resource Center, and has anyone tried that, or has it helped their patients? So I think the idea here that I'm hearing from our callers is that what's out there to help people navigate these waters?
There's quite a bit of help in the area on agencies on aging, and that's actually a toll-free number that's available through the state of Minnesota, although it hooks us up with a regional hub.
So that would be good for any of our callers, really, for how widely we're broadcast. Okay, great.
So how do they help? Well, maybe somebody needs transportation. Maybe they can't drive anymore, or they're unable at this time to drive, and so that they can help with transportation. Maybe they need respite care for a spouse, and so they can help set that up. Maybe they need home care for post-op recovery, and so that they can help with advising who's available in their area for home care. Now, the hospital or clinic social worker, if there is one available in the clinic, but certainly there is in the hospital, they can help too with setting those things up.
Okay.
So,
And would that include things like Meals on Wheels or?
Yes.
Okay, great. And then, like I said, we had another question that talked a little bit about, and maybe if you're familiar at all, with any other models that are being explored to help keep people staying in their home, or even alternative models of living. And I'll give an example that I've heard of is really sort of a mixed use, multi-unit housing. So what you have is you have younger, healthier people and families. I think this is part of our conversation around socialization, mixed with older population and maybe individuals who may need in-home care, but are able to still stay really vital and then partner around the family and have the ability to interact with them. I know we don't have that currently here, but I've heard of those kinds of models. Has anybody heard of anything else maybe that might be even in Europe or?
I haven't come across much. I've thought that would be a good business model to remodel some of our old two-story homes, bust out the backyard, because they usually have a big backyard, put in the master suite with lift capability, and then have college students help with the care who live upstairs relatively free. So I think there's lots of opportunity.
Yeah.
I haven't done that, but so you've got my business model.
Well, so I was going to say, as our population ages, we may have more opportunities to explore this. I do want to get to one other question here from Therese here in Duluth, who would like to know, if you have an underlying mental health condition, maybe bipolar, schizophrenia, does it predispose you to dementia?
I think that's a tough one because sometimes I see people who look like they have dementia because they have poorly treated mental health conditions. And certainly I have seen that before. But that doesn't necessarily mean that they're more likely to get the dementia in the first place, because what they have truly isn't necessarily dementia, it's a poorly treated health condition.
Yep.
So we have had a couple of questions. We're kind of nearing the end of our half hour on the following, which is Aricept and other drugs that might be helpful for those memory issues that are now the cognitive changes that are moving into dementia. So.
Yeah, Amy mentioned the MoCA test. Other testing has shown that these medicines can help us maintain those tests for about 30 months. If that's the time that I need to get my affairs in order before I go into the nursing home, or maybe my family needs, that's probably a good bridge. But then taper off the medication.
Okay. So one thing I've heard recently about for individuals, particularly those that are in skilled nursing facilities, are some of the upper respiratory infections. And I've recently heard that there's some that we often hear about in young children are now impacting our elderly family members that may be in these facilities. So would any of you, maybe Dr. Copeman, talk a little bit about that for us?
Yeah, one of the things that we found is that there's a virus called respiratory syncytial virus, or RSV. RSV, when children get it, they get very sick. They get something called bronchiolitis, or they have problems breathing. They become hypoxic. They wind up in the hospital. There's also a high incidence of RSV in the elderly. Now, if you and I, middle-aged, otherwise healthy, get RSV, it presents like the common cold. But as we get over age 65, if we get the virus RSV, not only can we get the upper respiratory symptoms that we get with that, but also tends to trigger a lot of the underlying illness. It leads to secondary pneumonias. It leads to exacerbations of congestive heart failure and those things. One of the reasons in facilities why we are checking that is because it's of isolation. RSV tends to be highly contagious. I know where I practice, we have like the RSV season. We kind of get ready for it because we know that it's coming. And so it can run rampant in a facility. And so if a patient is diagnosed with that, it's not that we have a direct treatment just for that virus, but it's the isolation preventing it from spreading so that other patients who might have chronic underlying illnesses may not suffer more from that.
Well, thank you for that, because I think a lot of us have been hearing a little bit about that in the news, and then also, like I said, when we go to visit our family members. Well, I think we're about out of time tonight, and with that, I'd like to thank all of our guests, Dr. Mark Boyce, Dr. Jeff Copeman, and Dr. Amy Greminger, and our medical student phone volunteers, Kaylee Evers, Mitchell Moe, and Courtney Wertnan. Please join Dr. Ray Christensen next week for our last program of the season on eye problems, when his panelists will be Dr. Charlie Ahrens, Dr. Lisa Graham, and Dr. Joseph Morehouse. Thank you for watching, and thank you for your questions. Good night. All right. Oh, good.
Another quick half hour, you guys.
Oh, I know. It just flies, doesn't it?
I'm like, tell me more, Mark.
Yeah, I am too. That's why.
I know.
I'm going, okay, yeah.
I had to get that one in there, and now, but boy, we had callers from all over. I mean, I didn't get to Gilbert, Knife River, and Kenosha Township. I mean, we had all these.
Yeah,
I know, but I'm pretty sure.
Oh, gotcha.
I'm pretty sure. Yeah.
Gotcha. That was the first thing.
But we covered all this. So anyway, good job. Thank you.
It is fun.
Yeah, I was doing some research the other summer about like what makes a high quality activity in nursing.